I'm Dr. Jelaine Berquist, social media editor for Seminars in Arthritis and Rheumatism. The following is my interview with Dr. Katherine Wysham. She is a Seattle, Washington-based rheumatologist and the lead author of the article, Low Cumulative Disease Activity is Associated with Higher Bone Mineral Density in a Majority Latinx and Asian US Rheumatoid Arthritis Cohort. This article is available in the April 2022 issue online. Keep watching for details regarding this study. Well, thank you for joining me, Dr. Wysham.
Happy to be here. Thanks for having interest in this manuscript.
Well, great. I understand the study. You were trying to further sort out the association between rheumatoid arthritis and bone mineral density. Can you walk us through the study in terms of the purpose, methods, and results?
Sure. I think it's important just to understand what we know and what we don't know with rheumatoid arthritis. It is a risk factor for osteoporosis in the general population FRAX calculator, but that really makes it a dichotomous risk factor. And we know as rheumatologists that rheumatoid arthritis is not just an on-off switch. There's a whole spectrum of severity of disease. And so part of my passion is to try and understand risk factors within the RA population that can help us better understand osteoporosis risk and fracture risk. So in doing so, there had been some evidence about disease activity as measured by different indices, some of which we don't use currently, and modeled in different ways. But my hope was to try and understand whether cumulative disease activity, so the chronic exposure of disease activity, was associated with different levels of bone mineral density. And so for this project, we decided to measure cumulative disease activity and represent it as low or in remission versus moderate and high disease activity to understand if it did have a significant association with bone density. And another cool thing about this project is we were able to do it in a cohort that was really unique. Traditional rheumatoid arthritis cohorts are either set in a country from which they draw the population. This was set in California, where we have a very diverse population, and so we were able to understand and evaluate this question in a cohort that was mostly Latinx, but also had a high prevalence of Asian participants as well. So for the methods, we studied all participants in our safety net hospital. Because we were studying bone density, everyone was required to have a DEXA. And we wanted to have at least two disease activity measures precluding that DEXA, because we were really trying to understand, although we were looking at this in cross-section, whether the cumulative disease activity up until that point was associated with the bone density. Our primary risk factor was femoral neck bone mineral density, which is the least affected by degenerative changes. And our primary exposure was the cumulative disease activity as measured by DAS28 ESR. And we tried to show a picture of how we did this area under the curve calculation. Traditional area under the curve is kind of a rectangular area under the curve. But what we did is we created little trapezoids between each time point, suggesting that disease activity doesn't just stay static between month A and month C. It probably does a lot of things, but at least it climbs to that point. So with using this trapezoidal approach, we were able to better estimate the cumulative exposure. And then we took the cumulative disease activity and we're able to divide it by observation time, because people were in this observational cohort for varying amounts of time. And we tried to put it into meaningful categories. So we categorized it as low or remission versus moderate and high disease activity. So we also controlled for other important variables that we know are risk factors or influence bone mineral density, such as age, sex, race, disease duration, body mass index, and medications. We also controlled for ACPA positivity and osteoporosis medication use. And we performed sensitivity analyses evaluating other bone mineral density sites, such as the lumbar spine and the total hip, as well as evaluating whether we use CDAI rather than DAS28-ESR as our primary measure of disease activity. So for our results, we found that low cumulative disease activity as measured by DAS28-ESR was associated with higher femoral neck bone mineral density. And this finding was statistically significant in our multivariable model. And our sensitivity analyses showed that we had the same significant association with the total hip. And we did find that low disease activity was associated with higher bone mineral density at the lumbar spine, but that finding was not statistically significant. And when we substituted CDAI in for the DAS28-ESR, we found the exact same pattern, statistically significant association with low disease activity at the femoral neck and total hip, but a non-significant association with the lumbar spine.
Perfect. Well, thank you so much. One last question. After doing all of this, will this study, what your findings, will this change the way that you practice rheumatology in the future?
That's a great question. This is a cross-sectional paper and it's an observational study. So I can't say that this one thing causes the other, but I think that this paper supports the idea that cumulative disease activity, which likely represents cumulative inflammatory burden, possibly exposure to glucocorticoids and maybe altered body function over time, is an important risk factor to consider when considering screening for bone mineral density screening in rheumatoid arthritis. So if you have two patients in front of you and they don't meet some of our unclear guidelines on who to screen in RA, and someone has had long-standing, very high disease activity RA, but they're only maybe 40 years old versus another person who's newly diagnosed, I think we can put our thinking hats on and would probably think about screening this 40-year-old who has had a lot of disease activity and medication exposure at that younger age. Granted, there is no guideline to really support that. So I hope that this would support our clinical decision-making and then hopefully in the future help develop guidelines for bone mineral density screening for this high-risk population.
Great, thanks.
Of course.
For the complete article, please visit www.sciencedirect.com/journal/seminars in arthritis and rheumatism. If you're interested in more video content from seminars in arthritis and rheumatism, please hit the subscribe button. Thanks for watching.